problem of early identification. So I think you will enjoy his presentation. As I mentioned very early on to some of you who are just joined, we will be recording his presentation. People will, as participants, will be muted until after his presentation. Then we'll open it up for questions. The question and answer session will not be recorded, so you don't have to worry about that. Thank you very much, and Roald, it's all yours.
Thank you, Fred. Thank you. And hi, everybody. So my name is, it's difficult to say in English, Roald again, which is the Norwegian pronunciation of it. I'm a professor at UiT in Tromsø, Norway. Tromsø you can see behind me as my virtual background. So it's the most northern university in the world. We're about more north than Anchorage, so at 69 degrees north, so it's almost the North Pole. I'm a professor. I have a PhD in psychology, and I am a professor of child development at the Department of Special Education. And then I'm also an adjunct assistant professor at the Yale Child Study Center, and Fred Volkmar was my supervisor. So that's short about me. I also have a daughter with autism that is 14 years of age. So both parent and professional. And today I'm going to talk about the complexities of early identification using screening instruments. And by this title, we have to go through what is early identification, what is the challenges with early identification alone, and then what's the challenges using the screening instruments in the process of early identification. And we have done a series of studies, which I will talk about, that have assessed how well these screening instruments actually work. And we will get back to that later in this lecture. So yeah, my primary research interest is to look at early development, behavioral markers, temperament traits, and development in general in small children. And most of the studies I've been working on together with Fred Volkmar and others are utilizing a Norwegian study called the Norwegian Mother and Child Study, or actually it's just been renamed to the Norwegian Mother, Father and Child Study, which is a prospective general population study that actually follows kids or the mothers from their 6 months pregnant and until the child is 18 years of age through questionnaires, through clinical assessment. There's a number of sub-studies that have looked at language difficulties where they excluded all the kids that had ASD. We have an own ADHD study and also something called the ABC study, which actually assessed 1,000 kids for autism, 300 controls, and the rest of that were regarded as risk based on 8 criteria, not only one screening instrument, but 8 criteria. Basically because they didn't get any children to participate if they just used the screening instruments. So that's what we're getting into. I'm the father of 4. I have a 14-year-old daughter, as I said, with autism. So basically, we can start here because it's important to know that autism spectrum disorder is persistent deficits in social communication and social interaction. We have the restricted repetitive patterns of behavior, interest, or activities. And the symptoms must be present in the early developmental period, as Fred also talked about the last time. When we talk about early identification of the disorder, it's important because it provides access to benefits both in the US and in Norway, such as intervention. Also in Norway, it provides you with financial support, the right to have an assistant, So there's a great deal of services that you actually need to have a diagnosis of autism to get. And we also know that early identification is considered critical for improving future outcome, because as soon as we can identify the disorder in an individual, we can also provide intervention, and earlier intervention is regarded as very important for future outcome. But there are some points that make it very hard, and that are the challenges of early identification, and that's the fact that the symptoms are very heterogeneous. They often have different time and patterns of onset, so they might show up earlier, later in the developmental period. It might look differently in different children, and which we will also talk about today is that we see that there are different symptoms in males and females that might, in fact, bias the prevalence of autism in girls. So what we know about time and patterns of onset is that we do know that the heterogeneity is large. We know that it's large in behaviors, core symptoms, adaptive functioning, and cognitive skills. Do you know what adaptive is? If it's the skills that you actually do on an everyday basis, just to make that clear. Cognitive skills is most of the studies that have looked at cognitive skills and the heterogeneity in it is related to IQ and executive functions. We also do know that, and it's an increasing awareness of the heterogeneity in the time and patterns of onset, that it might be different in different subgroups of kids and in individuals. So actually some show these certain patterns early in the development period, some later in the development period. So that's also one of the knowledges we have and the challenges. And it manifests differently depending on verbal and non-verbal skills. So we do see that children also that have language have also different manifestation of the disorder compared to those without verbal skills. And all of this knowledge we have that autism is so different in individuals and in different subgroups is also what creates this immense difficulty in the detection, early identification, and treatment planning of this group of individuals. We also do know that you need there need to be a greater social demand for the disorder to become evident, and that's why they changed the criteria in the DSM-5 to instead of saying that it had to be present before the age of 3, it was changed to in the early developmental period, and because we know that some might receive or some might have patterns that occur later than others. So so you need to have, there need to be a greater social demand sometimes that exceeds the child's social skills for that disorder to become evident. A good example is, for example, if you have two babies playing together, it's not the greatest of the social demands in that situation. But when you touch upon preschool and 5-6 years of age, these social interactions become much more complicated, and that's often also when we identify kids. And it's also the challenge is that the symptoms, they might not even be evident at 18 months of age. So the American Academy of Pediatrics, they suggest screening at 18 and 24 months, but for some, it might not even be that the symptoms are evident at these 2 time points. So these are just challenges related to the time and patterns of onset. And when we look at screening instruments, during the last years, there's been a massive discussion regarding screening. And in Europe, we have the NICE guidelines, and we have research that say that research that say that there is not enough research to recommend universal screening. That meaning screening everyone in the population. But we know from studies that it might enhance early identification for some and provide early intervention at an earlier time. Screening should be very brief parent-endorsed questionnaires, like 20 or 25 question maximum. We do have some screeners that are longer, but the most used one are the MChat, which is also in a revised version, MChat-R. Very similar, but we can discuss that later on. And these are 20 and 23 questions to the parent or caregiver. But there is a lack of evidence that universal screening is effective. We do also know from a study in Canada that the price of universal screening is very high. For each child identified, I think the price is somewhere around $750,000 US, because there are so few that actually are identified by these screening instruments. The American Academy of Pediatrics recommends screening at 18 and 24 months. You can also screen at other time points, important to say. Some of the challenges about screening is that the MChat, from the studies we have conducted in Norway with this huge data set that actually follows the kids throughout childhood, is that most of the cases are false negatives. That meaning that they get a diagnosis later in childhood, sometime. It might be at 4 years, it might be at 8 years, but the screening instrument is not flagging them as at risk for ASD. So that's about 70% of the cases in Norway out of a sample of, we had about 60,000 individuals, and we'll take a look at that afterwards. There's also some evidence that the MChat does not work as well as intended in universal screening settings from the US, from a paper by Guthrie in Pediatrics last year, which also showed some of the same challenges. A recent paper we conducted shows that the MChat identified children with lower IQ and more language issues. And some of the challenges here are that there are few prospective general population studies. Most screening studies are conducted and instruments are validated by including the screen positive, the kids that are regarded as at risk, and then they do an assessment, while the children screening negative, a very small portion of them are seen in clinic, and very few studies are following these children up over time. So we don't know really what happens to the screen negatives. So this is just challenges. And we know that at the same time, as we know about these difficulties, we know that the prevalence is increasing. Over the last 10 years, we have had a 0.38% rise in the prevalence in the US in the CDC report. In Norway, we've gone from a prevalence of 0.7% to 1.2%. So that's a fairly good rise in the prevalence, both in Norway and in the US over the last 10 years. At the same time, we know that there is a discrepancy between the number of males identified and diagnosed and females. In the lower, or in the area where we also have individuals with comorbid intellectual disability, we know that these numbers are closer to each other. So it seems like that is a factor. And also we know that in the other end of the spectrum, where we have children within the normal range IQ, we do see that there's even more boys per girl diagnosed with autism. So we do see that IQ and intellectual disability is something that affects this male to female ratio within the autism spectrum. And regarding sex differences, we do have some knowledge that there are sex differences in autism. For example, we know that females are more oriented towards social stimuli. We also do know that males tend to score higher on externalizing behaviors than females. So they have more behavior outwards, for example, temper tantrums and other problem behavior. While females more often internalize these behaviors, so more anxiety, social anxiety symptoms, depression. And we also do know that females are later identified than males, especially when they have complex phrase speech. We know that there is a fairly big difference between males and females. And we also do know that females have lower levels of repetitive and restricted behaviors. However, it might be that they have more of the stereotyped interest, but they have lower levels of this very visible externalizing behavior. And this presents some challenges because we know that females might, with less externalizing behaviors, might be missed because they go under, we don't suspect them of having ASD. It's easier to be a quiet girl with internalizing behaviors and don't raise any red flags. While if you're a boy with a lot of outwards externalizing behavior, it might be that raises some concern earlier than for females. Some studies have also suggested that females might require a greater genetic load to be identified, that there is a genetic protective effect in females. And some of the issues with the autism spectrum is that most studies have small samples of females included. And that might complicate the search of a female phenotype or a female autism diagnosis. The other thing we know is that from studies in adult women, we know that they are also better at camouflaging symptoms. So they actually are better off maybe learning the social correct way of being in social situations or how to respond to social stimuli better than males are. So they're better at camouflaging symptoms. And that's a very interesting article I recommend you to read. It's called Late Diagnosed Women with Autism Spectrum Condition. So these are some of the issues and challenges we have about early identification. And one thing that remains very interesting is that even if there is a recommendation to screen at 18 and 24 months of age, the mean age of diagnosis is still much higher than 18 and 24 months. It's about 4 years of age. So that means that if we are doing the screening procedures and it still remains the same age of diagnosis, it means that there's something that doesn't work. And throughout multiple papers, we have looked at both sex differences, but also how well these instruments work in identifying autism. And we will take a look at some of them now, so you can get a hunch on what they show and how we do it. I will go through one of them first of all. First, we looked in high-risk settings, that meaning children that was referred for an ASD assessment using a very short checklist. To no surprise, this instrument performs very well in identifying ASD compared to not ASD, because they're already referred for an autism assessment. So that affects how well an instrument performs. In terms of sex differences, we looked at various items. For example, eye contact, interest in others, pointing skills, language, pragmatics of language, repetitive behaviors, and unusual sensitivities and preoccupations. And it was in 123 kids that were referred to an ASD assessment at Mount Sinai. What this study found was that the instrument performed equally well across males and females, but there was some small differences between males and females, and that was that the females had more language deficits, while less oversensitivity issues compared to males. And this was a clinical study which looked at screening in a high risk setting. So that actually shows us that the screening instrument is good. It shows that it works at identifying autism compared to children with other developmental issues, not compared to typically developing children. So what we found from this was that it was comparable performance in girls referred for ASD assessment compared to boys referred for ASD assessment. But when we go over to the big Norwegian data set and we looked at sex differences on the MChat. So we took the MChat and we looked at parents reported and endorsed males and females with autism and without autism differently than males differently than females. So we looked for a sex effect and see if there were differences in how this instrument and the parents rated boys and girls. What we found was actually, and we had 53,738 children included in this study. So we had a pretty massive chunk of kids included in the study. As you might see, there were 185 that have later received an ASD diagnosis, but only 32 of them were females. And that's kind of something we see in different studies. It's actually that there's a small portion of females. What we found in this study was that females that later were diagnosed with an ASD diagnosis had a much higher score on the MChat compared to the boys. And they had, in the typically developing population, we saw that there were not these differences. So females scored lower than boys, but inside the group, the ASD group, we saw that males scored higher on the total score of the MChat. So approximately female had around 5 on the MChat, while boys had 2.5. So that's almost twice as much. So that might indicate that females have a greater impairment in this group. What we found when we looked at each item to see if there were any differences in how the males and females, or girls and boys, were endorsed by the parents on the MChat, which saw that females showed a strength in joint attention. So females with ASD at 18 months, they showed a strength in following a pointing gesture better than boys with ASD at 18 months. However, we also found that females had a weakness, or girls with ASD had a weakness in imitation of a facial expression. But that item on the MChat is it's not a very complicated imitation. It's a response to the smiling, or if they imitate your smiling towards them. So we found some small evidence of actually there being some sex differences already at 18 months comparing boys and girls with ASD. But what's important, I think, to drag out is that females showed some strength in this joint attention. It's following a pointing gesture. We will just move on. All the slides will be put out so you can look more thoroughly on each of the results sections. And then when we try to look at the MChat and how well it performs in this population, we looked at developmental and temperamental profiles at 18 months in these kids that were actually missed. So we did a study that actually showed that, including 68,197 children, 228 of them had ASD, all of them failed, or all of them passed on the MCHAT. So there is a very high number of what we call false negatives. 76.8% of all kids later diagnosed anytime in childhood with autism were screening negative on the MCHAT. Actually, so there was no concern raised by the MCHAT. So we took a closer look at the individuals that actually participated in this study, because we wanted to know, so if 76% of the children with later diagnosis of ASD pass the MCHAT and do not raise any red flags, are there other domains that actually can show us if there is something about them that might be concerning at 18 months? And when we looked at, we used something called the Ages and Stages questionnaire, which has another way of asking questions, and it's also graded with not yet, sometimes, and yes, compared to the MCHAT yes and no questions. And when we looked at the kids that screened negative but got an ASD diagnosis on the ASQ, we can clearly see that there is something about them in both in communication, social skills, fine motor skills, and gross motor skills, which is very interesting because we didn't actually embrace these things using the MCHAT. We also did find some differences on temperament, while not very much, but we found that actually, and it's very interesting, we found that girls with ASD were less shy than boys with ASD and boys and girls without ASD. And we tried to look through this and we tried to find out what could this be rooted in, and it was actually something that we might be related to inhibitory control. So it might be that they're less inhibited than boys. But as you can see from the two graphs, A and B, you can see that the difference between boys with and without ASD at 18 months is a bit smaller than the differences between girls with ASD and the girls without ASD at 18 months on figure B, which you can see now, indicating that maybe the impairment in girls when they have an ASD diagnosis later in life is greater than we see in boys. But this shyness was something that we actually thought were very interesting, because it might be that this can trick someone to think that the child is more social. So, but it's all about inhibitory control, being less inhibited towards strangers, for example. So from this last study, which was published in Pediatrics, we know that boys and girls who later receive a diagnosis of ASD, they have delays and atypical features in the areas of social domains, communication domain, and motor domains, even if the MCHAT shows that they fail 0 questions. They pass on everything. Even if there are two, and here's a very good example. There is a question on the MCHAT that's asks if the child can walk unaided at 18 months. And most parents in this sample rated the child, yes, they can walk unaided at 18 months. But when we looked on the other questionnaire, the parents said sometimes. So that's, particularly in this study, is probably giving more nuances to it than just the MCHAT. So we know that from this study, we know that 76.8% of kids with a later diagnosis with autism pass the MCHAT. No red flags raised, no follow-up, they just pass it. And false negative females, they have similar but more pronounced difficulties than the false negative boys. So boys with autism that later receive a diagnosis. which indicates that maybe there is a greater severity of symptoms in females. But we see this lower levels of social inhibition or fearfulness in females later diagnosed with ASD. So this was a very interesting study. And a colleague of mine, she did a study in 2014 finding the same numbers in the same sample. And so we were started thinking, so what does screening instrument actually pick up? What's the point of to do screening if you actually miss 76.8% of the kids? And then we tried to think, we actually know from Norway that one single question is more predictive of autism than the whole MCHAT. And that's, have you or anyone around your child express worries about your child's development? But it's also catching a lot of other things. So the question here is, what do screening instruments pick up? And in our latest study, we looked at multiple measures. So we looked at the Wineland communication domain, which measured functional language. We looked at IQ, cognitive skills, and we looked at symptom severity measured from one of the instruments that we use in the diagnostic process called the ADAS. And we used data from this Norwegian study, and we took the clinical sample from this study to see what is it about these children that we identify at 18 months with the MCHAT. And we found that the MCHAT identifies a great portion of children with intellectual disability, which is not specific to ASD. So it mistakes intellectual disability for ASD. At the same time, we also do know that these false positives, so children without ASD, maybe with intellectual disability or other disorders that are picked up by the MCHAT, they might need access to the same services or similar services and interventions as autism. So it's a discussion, is it good or is it bad that we detect also kids with other diagnoses? We know that with the new MCHAT revised, the MCHAT-R, we know that the number of false positives are much lower. And this up for discussion if that's good or if it's bad, because we don't know if it identifies more of the children that actually receives the diagnosis of ASD later, because they don't have follow-up data on those one. Furthermore, we know that from this study, we know that the MCHAT actually picks up and identifies ASD children with greater symptom severity. That meaning that they have more of the prototypical ASD symptoms. We also do know that they have decreased functional language and lower IQ. So the group of children with autism that are identified by the MCHAT at 18 months, they have lower scores on both cognitive skills, language, and higher severity than the children in all the other groups. So that's who the MCHAT actually identifies. So that meaning that children within the normal range IQ, they seem to be missed by the screening instrument. Furthermore, we did a check. So how is the diagnostic situation in this group? So as you can see from this table, the MCHAT actually picked up 81% of children with intellectual disability without ASD, compared to 30% of children with autistic disorder, 22% with PDD-NOS. And it also detects a number of children with language disorder without autism and without intellectual disability. So there is a strong evidence that actually MCHAT identifies kids that are lower cognitive skills at 18 months. So this has some conclusions. early identification seem to be very hard using these screening instruments alone, as 76.8% of them actually are never identified by the MCHAT. And we know that this is the same for some of the other instruments also, which we have in Norway. We have something called the ESAT. We also do know that there is a very high rate of false positives, which might be because there are children with other disabilities or disorders that are identified with screening instruments, but it might also be because there is differences in heterogeneity in symptoms, time of patterns and onset, as well as the properties of these current screeners. It might be that these symptoms need a greater demand socially to be evident for parents also. It might be that parents need to know more about the phenomenology of the question. So if you ask parents about, for example, a good example from this screening study was that most of the parents had endorsed their child to do the following behavior. Does your child like to spin around on the floor with her hands out? And all the parents said yes, because kids like to do that. But actually, that question was intended to be about repetitive behaviors. So a lot of parents responded yes, while actually thinking about something that's normal for kids to do. So we have to also maybe help parents better understand the questions we're asking them. For example, functional play with a toy. It might be to play with a car, but if you do it for 8 hours, it's not functional. It doesn't necessarily need to be that the child is spinning the wheels. It might be repetitive in other ways. So we need to know that parents actually know what they're answering. And that's a big challenge. We also do know from our studies that these children that are not picked up by the MCHAT, they show atypicalities in development at 18 months, even if the screening instrument is flagging them as no risk. And we know that these instruments more often identify children with intellectual disability and other disorders, not only autism. Regarding sex differences, we know that there are marked sex differences, both in high risk and low risk samples. And they're often related to joint tension, oversensitivity, shyness, or social fearfulness and social factors. And we can think about it that also from previous studies and from these studies, we can think about these as strengths in pro-social behavior. Or it might seem like they have strengths in pro-social behavior. So it might make them less socially avoidant. And that again, we might interpret them as more social. In the end, there is a need for improving these instruments that we are using now, so to make them more sensitive to both sex differences, but also more sensitive towards the fact that we now know that they are identifying children with greater severity and lower IQ. And we need to improve understanding of parental interpretation of these questions and how this affects the endorsement of these autistic symptoms. One big problem is also that in our studies, we know that a lot of individuals had to be excluded due to the fact that they crossed both yes and no on the MCHAT, which might be that it's a sometimes because it's not graded. And we see that there is, when we look at these children, comparing them on the MCHAT and on the ASQ, we do see that on the MCHAT, we don't see any atypicalities, but on the ASQ, we see that there are differences in development, both in social communication and in motor skills. So we have some implications. So where do we go from this? And I think that it's all about examining if new items, if we can make sex-sensitive questions, different graded responses to look if that can improve screening. However, I do think that screening alone is not enough, and it's not very cost effective. And it also might raise some unnecessary concern among parents. For example, we know that children that are born 2 or 3 months preterm, they're more likely to fail the MCHAT. So it might be also that there are some negative consequences to screening absolutely everyone in a universal screening setting. I think that the combination of screening and using developmental surveillance at various time points, as we do in Norway, we have developmental surveillance both in kindergarten and baby well checkups of the children until they're 6 years of age, which I think is the recommendation both in Norway and in the rest of Europe, actually. There is also important to think about this, as there might be other developmental markers that might provide more general signs that is not autism specific. For example, in a study from 2007, Kasia Shavarska showed that the thing parents are first worried about is motor skills, and then social skills, and then the more typical ASD signs. And the mean age of these concern were 15 months. So if you're concerned at 15 months, you should have a tool that is able to measure these concerns. However, still, we have the conclusion that most children are identified much later, at 3 or 4 years of age. So there is some issues also about how we conduct research and how we validate these screening instruments. Is that we look at the children that screen positive, and then we don't follow up on the children that screen negative. And that's an issue because we know that kids that are diagnosed with autism, they receive their diagnosis everything from between 1 year and 18 when we look at the child group and adolescents. So it's a very widespread group and heterogeneous group in terms of when they get their diagnosis. So most children are actually missed on this most used screening instrument, the MCHAT. And the question is then, what is the fundamental drive for universal screening? And we need to think about it more closely and think about, is there anything we can do about the screening process or anything we can do besides the screening that is more effective? Is it good or bad that it also identifies other children with other disabilities and other disorders? And what are the implications of, for example, improving the MCHAT to the MCHAT-R and reducing the number of false positives? Children that are screened positive and might have other difficulties. Is it good or is it bad? So this is a big discussion that is not very simple to answer. But in terms of improving the ASD specificity of these instruments, we need to get more knowledge if the MCHAT-R actually identifies more children with autism. Preliminary results from Norway show that it doesn't. Then we need to know more about who is in the group that actually is now not false positives anymore. Is it children with other disabilities that needed some kind of services? So this is something that is important to discuss. In the end, is also that females might have different symptom patterns than males. It might be other things that females would benefit from, or parents of girls would benefit from being asked. So we still don't know enough about differences in screening between boys and girls. But I think that we need to consider it in the future to look at, is there any differences in what identifies girls compared to boys using these checklists? And in the end, I think that a lot is about developmental surveillance and parental concern. that is some of the earliest and best predictors we have is parental concern. And if a child passes all of the question at 18 months, but still gets an ASD diagnosis, we have either constructed a questionnaire that is asking the wrong questions, or the parent isn't concerned at that point. And that might indicate that these symptoms are not evident at 18 months. Then the next question is, will the same children be screen positive or screen negatives at 24 months? And that's also a big question that we don't know enough about yet, because we don't have prospective data on that at this time. Or we have in Norway, but in the US, there's very few studies that have prospective designs that can look into that. So concluding remarks, I think I would say that regarding sex differences, I think that there are some things that are prototypically regarded as autism spectrum disorder. There are some things that are very rooted in the history and in diagnostic criteria, which is primarily based upon male samples of ASD, that actually might make it difficult to find the best description of girls that are later diagnosed. But given that girls seem to have some strengths compared to boys in the social domains, it might indicate that actually, if they preserve some of the other qualities, we know that females are superior to boys at 18 months, because we know that from Norway, we know that the only thing boys are better at than girls at 18 months is climbing on things. So for the social bit, it's actually important to think about if they preserve some of the things that they're weak at. For example, severity of symptoms. We know that girls with autism have higher symptom severity and more language difficulties. If we can think that if girls did not have those two issues and kept all of these strengths they show from various studies, it might make them less likely to be identified by a screening instrument or a diagnostic instrument. It doesn't necessarily indicate that they would be without difficulties, but maybe they have other difficulties that are not embraced by the current instruments. So this is just an idea, and I think it's important to think about also sex, age, and IQ when we think about screening. It's not very surprisingly that most of the children identified had lower cognitive skills and had more language issues and a greater symptom severity. So then the question that we have to go further into, which we don't have any data on right now, and we don't have any answers to it right now, it's how do we actually make these instruments better, or is it better to create something new? And that's what I had. And I would like to thank Fred for having me, and this group of fantastic people that have been a part of working on these articles. And in memory of Dom Cicchetti, which was one of our co-authors on all of these publications, I will put the reference list, also send it to Fred, so you can also read all of these studies. And I would like to thank you for having me. And in the end, I would like to mention the study by Kasia Shavarska. I will put those also into the slides, so you can see their project at Yale, the Center of Excellence.